got almost 40 people signing up, so that's pretty good.
Yes. Great.
Okay, so it's my pleasure to introduce Dr. Robert Hegele. He's a distinguished university professor of medicine and biochemistry at the University of Western Ontario. He's director of the London Regional Genomics Center at the Robarts Research Institute. We're just chatting that, I spent several years down there many years ago. He is also a staff endocrinologist who has a very busy clinical practice following over 2,500 patients. He's a Wolfe Distinguished Medical Research Chair. He also holds the Edith Skulik-Vinet Chair in Human Genetics and the Blackburn Chair in Cardiovascular Research. He's published over 800 manuscripts and has been cited over 58,000 times with an H index of 116. He obtained his medical degree at the University of Toronto. Then he did his internal medicine and endocrinology at Rockefeller University in New York City. He then went to Salt Lake City, where he did human genetics at the Howard Hughes Medical Institute. And he has an incredible track record with discovering 25 human molecular genetic diseases in his lab. So he also is been in the top 1% of the highly cited scientists by the ISI, and has many awards that include the 219 American Heart Association Lyman Duff Award, the 2020 FH Foundation Pioneer Award, several times the Young Investigator Award of the American Federation for Clinical Research, American Heart Association Top 10 Scientist Discoveries, and many others that I don't have the time to go over. So it's really a pleasure to have Rob today with us. So you can take it from there.
Well, thank you very, very much, Carlos. And so I hope everybody can see, just to confirm, you can see my slides. Okay, my first slide.
Yes.
Okay, very good. And so I just did a scroll down to see the participants, and I see so many familiar names and friends, and I wish I could like personally say hi. I mean, like the group, and even some people from Edmonton as well. So like the group in Alberta, I mean, all of you have contributed so much, and I have such a high regard for cardiac sciences in Calgary and Alberta. And so anyway, it's my honor to have this opportunity to speak with you. So today I'm going to be the new lipid guidelines. It's sort of the elephant in the room. They're going to be published very soon. I can't tell you exactly. I was even thinking possibly today might be the day that the guidelines might come out, but they're not out. So I have to. They're not published yet, but I can talk a little bit about what they might say. I can't really officially talk about them because they're not officially published. So today's talk is going to be reminding you, and I certainly don't need to remind you about the importance of LDL in cardiology. And then also we have these new markers, ApoB. Well, ApoB, of course, in Canada, we know about ApoB very well because of, the sort of pioneering work of Alan Snyderman in Montreal. So Canadians know about ApoB, but around the rest of the world, it's more of a newer thing. LP little a, and then also triglycerides has been an issue, an interest of mine, where these all would fit in going forward. And then we're going to try to anticipate the new Canadian lipid guidelines, and then also the impact that this could have on treating patients who are at risk of cardiovascular disease. So I'm going to start with a case report. This is a patient of mine. So he's from Aylmer, Ontario, which is just about maybe 30 minutes outside of London, rural community. He's a farmer, actually in pretty good shape. No obvious risk factors, non-smoker, presented with acute chest pain and had a STEMI, and then had a single stent put in. He had no family history of dyslipidemia or coronary heart disease. So we're going to keep coming back to this case. We're going to go through the evolution of his we'll go through the slide here. So his pre-treatment lipids. Okay, so this was he never saw a doctor before. So his first presentation really was his MI. And his total cholesterol was 6.3, triglycerides 5.4. Okay, so in the lipid world, we would call this a combined hyperlipidemia. high cholesterol, high triglyceride. And in fact, the triglycerides are so high that the lab is not even going to try to give you an LDL reading. So you're kind of stuck with using the non-HDL. Non-HDL is fine. The new guidelines will tell you that non-HDL, you can use it virtually interchangeably with the LDL. It's maybe not a number that we're as familiar with as LDL. But anyway, the other thing, he's got a low HDL. So the HDL 0.65, normally should be higher than 1. This is a package deal, usually with the high triglycerides. And then the non-HDL. So non-HDL, my rule of thumb is that it's about a conversion factor of 1.3 with LDL. So like LDL of 2, non-HDL on average will be like 2.6, something like that. So you can go backwards. So here, at non-HDL of 5.7, so that means like the LDL is going to be around whatever that is, 4.2 or 4.5, something like that. And then the ApoB is quite high. So ApoB, we're targeting a level of less than 0.8 or maybe even 0.7 for somebody at high risk. So 1.8 is really high. So this guy's got like, dyslipidemia that he didn't know about. And so then he gets put on, he goes to the unit, gets a stent, gets put on Lipitor 80, clopidogrel, metoprolol, perindopril, aspirin. So he goes on to sort of broad spectrum anti-atherosclerosis treatment. And now, question for you. Okay, he comes back 8 weeks later. Cholesterol is now down to 5.4, triglyceride down to 3.3, HDL has come up. LDL has been, now you can finally read the LDL. It's so let's say we guesstimated it was 4.5, it's now 2.5. And the non-HDL is down from 5.7 to 3.8. ApoB is down to 1.2. Okay. And this time he got an LP(a) measured. So we'll talk a little bit about LP(a). None of the treatments that he got would affect the LP(a) level. So that was pretty much, in fact, if anything, the statin would raise the LP(a) a bit. So he also has a high LP(a). So he's got like, combined hyperlipidemia, low HDL, high ApoB, high LP(a). It's like he's got, full deck, God dealt him like a bad hand of lipid susceptibility. So the question is now, okay, so here are the two things to look at. His LDL is 2.5. ApoB 1.2, and his triglycerides are 3.3. So what would you do next? He's just on single high dose statin, which he's tolerating okay. So what's your next treatment? Okay, what would you do? Start him on a keto diet, switch him to rosuvastatin 40, add ezetimibe 10 milligrams daily, go to a PCSK9 inhibitor like evolocumab, for instance, or the triglycerides are high, and you may have heard about this Reduce It trial. I'm sure if you're anything like me, you've been bombarded with information on that. At this point, would you add icosapent ethyl, which is then for the triglyceride indication? Okay, so which of these would you do right now? And then you could even do, nothing to say that you can't start the diet and add a drug, but if you had to do one thing, what would you think about? Okay, so we'll come back to it. So we're going to first of all reflect on the importance of LDL. So this is a case that I saw with my MD PhD student Julietta, who is just an amazing student. She wants to do cardiology, so she's going to defend her PhD this summer and then go back and finish med school. This is a patient we saw together in clinic. And so this is a lady who didn't really have that high lipids. I mean, her LDL was high enough. It was 2.95. She was 55 when she came in. And she was referred with these xanthelasmas around her eyelids, which are typically findings that you would see in genetically high LDL cholesterol. So you can see, around, especially around the left eye, these two large lipid-laden lumps. And then, I can just pointing them out with the cursor, but you can see what I'm talking about. And then the right eye, not as pronounced. And so she was interested in going for cosmetic surgery. She'd never been treated for lipids, and there was really no history of coronary disease. But the point that I wanted to make here is that we actually on spec, and she agreed to it. We said, okay, well, let's put you on a statin, in this case, rosuvastatin, 20 milligrams. So it wasn't for a cardiac indication, but it was to see if we could get the LDL down low enough that we could cause regression of these lipid-laden skin lesions. So this is not like usual treatment. And we know that, in fact, if you don't treat the underlying cholesterol, she can go and get like laser treatment, or like get even like surgical treatment. But eventually those xanthelasmas will come back. So anyway, we treated her down. You can see, good effect from the statin. LDL down to 1.24. So good news is she had no adverse effects. But you can see, sort of 3 years later, 4 years later, now it wasn't an instant effect, right? Like regression within a year, but really within about 3 or 4 years, they had pretty much cleared, and she was very happy with this. And so now I show this to patients. This is really then what goes on inside your arteries when these plaques develop in the arteries. And if we can get the LDL down to levels lower than we used to think. I mean, the old guidelines would say, LDL less than 2 or maybe 1.8, but now, like an LDL of 1 is not uncommon with some of our more advanced treatments. And then is that bad for you? Well, no, it doesn't seem to be any side effects. And that's what we seem to need to actually get reversal, to get regression. And this is something, John Mancini. So this is John and I looked at the data that came out of this was an imaging study, actually the Glagoff study of evolocumab. And there was the on-treatment LDL level. So the point here is that, all right, let's look at the LDL of 2. So our, like, say, 2016 guidelines would say LDL of 2 or LDL of 1.8. So this solid line here is the average on-treatment LDL, and then along the y-axis is the actual change in atheroma volume. So this is done using IVUS, basically. And so around a level of 2, you can see that the average person starts to get regression. Okay, that's the average, that's the line. But then this gray area is the 95% confidence intervals, right? So, there's the average, and then there's the distribution around the average. So there's still some people, 40%, even with an LDL of 2, that get progression of their plaque. So we asked the question, well, from this, study, at what level of LDL does everybody, like, is there no more regression anymore for anybody? Where this is like, where it zeroes out. And so it turns out it's a level of 1.5. So that's sort of, a one, and, the European guidelines now have a level of 1.4 for high risk patients. So these numbers don't sort of come out of the air. I mean, there is some sort of scientific rationale. So this is then just to make sure that everybody gets either, arrest or reversal, some regression. Okay, and then this is then matched by the large clinical trials that you're well aware of. This slide originally, I guess Salim Youssef and Sonia Anand actually had an original version of this slide, and it's been copied by everybody now. So along the x-axis is the amount of LDL reduction in your statin trial, and then there's an Ezetimibe trial here as well, and then the reduction in events along the y-axis. So pretty much, the more LDL reduction you get, the greater reduction, it translates to a greater reduction in events, and everything lines up on this line. And even with a non-statin, so before we had Ezetimibe, people would say, well, okay, this is just the pleiotropic effects of statins. You can't really say it's LDL. But in fact, now we have Ezetimibe, and then the PCSK9 inhibitors line up along this line as well. So those are definitely not statin drugs. They're not having all the magical pleiotropic effects of statins, but they're still causing regression commensurate with the degree of LDL reduction. What about alternate day statins? So this is just a clinical point. So I have, like, some patients that are, say, because they perceive that they're having statin-related myopathy or muscle aches. So we negotiate with them. And so the common thing, I've got now 200 or 250 patients that are taking alternating day statins, or statins 3 days a week, Monday, Wednesday, Friday. So of course, there's no clinical trial showing that, but this is from a couple of HMOs and observational studies in the US, these huge insurance databases. So what they've done is they looked at survival. So this is just who's alive, looking at all the statin users in their databases of, like, I think this might be 400,000 people. And there were then people who then were filling their prescription because they were coming back to the pharmacy and getting their statin dose refilled, and they could tell that they were taking it pretty much every day. And then there were the people who just stopped taking their statin. So this was their survival. But then the interesting thing was that there were some people that were coming back less frequently. They could tell, okay, they were still coming back, they were refilling their prescription, but based on the interval, they must not have been taking their statin every day. It was some kind of non-daily routine that they had like figured out. But they're survived. So like what this, that's this line here, the small dots. So the point here is that some statin is better than no statin. Okay, so we're trying to drive them down to now like these LDL levels, for sure less than 1.8. Could it be 1.4? Who knows what the lower limit is? But at least even just as a starting point, they should be taking something. So even an alternating day statin is better than no statin. Okay, now just like about 3 minutes on COVID. So statins and COVID. So there's in fact a huge literature now coming out about statins and COVID that probably maybe many of you would be aware of, but just to go over it. So this was a study from about a year ago where this was out of the UT Southwestern in Dallas. So what they did is, so this is an electron micrograph of the lung. And then those purple things are like the SARS-CoV-2 virus inside the lung. So this is like a pathologic specimen of somebody who's died of like respiratory failure. So what they've done is that the way SARS-CoV-2 propagates is through a protease. It's like, in that way, it's like HIV. It's the protease that then allows it to to take up residence and then spread and then like infect more cells. So that's the concept of protease inhibitors, right? So what they did is then they just took the main protease from the virus and they tested all known drugs to see what drugs bind to the SARS-CoV-2 protease. So you can see here, this is the list. So on the first, these are all antiretroviral drugs. Well, it kind of makes sense, it's a protease, and so that's how these drugs work. But then interesting, there's like, these other drugs here, daunorubicin, chemotherapy. But then also there's a statin. Rosuvastatin binds to the SARS-CoV-2 protease. Interesting. And then there's this observational study out of China where here they just looked at survival. So like this is then patients that got admitted who were sick enough with their COVID to get admitted to hospital. Some of them then were like, with their risk factors, and then were taking a statin. And then there were others that they tried to match them propensity wise, except that they weren't taking their statin. So they were matched for cardiovascular risk. So the only difference between the two groups was based on statin use. And the ones that were taking their statin had half the death rate. We're like twice as likely to get out of the hospital alive, to leave the intensive care unit. And this is 13,000 patients. And then at that time, there was this debate, well, could it be the ACE2 receptor? Maybe it would be like ACE inhibitors would have the same, but no, didn't seem to be. ACE inhibitors, there was no difference with ACEs or ARBs, but it would seem to be specific to statins. And this has now been replicated in other kinds of observational studies. So it's not a randomized clinical trial, but it is a consistent result. So here's another one. These are then patients that were admitted to the ICU and then who didn't make it out alive out of the ICU. What were they taking? So it looked like the drug that then was associated with the lowest hazard ratio of death, it was actually atorvastatin with a p-value of 0.8, a 62% reduction in risk. Steroids, not so much. Donald Trump's favorite drug, hydroxychloroquine. I think colchicine, interesting. There is now, a signal. There's a bit of some interest and controversy with colchicine through the study from the Montreal Heart Institute, but it does look like colchicine is in several independent studies seems to be having some kind of borderline significant effect on improving survival. And then, these other drugs not having an effect. Okay, so that's my word about COVID. So the way that this translates into clinical practice is that then this becomes an added incentive for my patients to stay on their statin. It's like, Doctor, is my statin going to interfere with the vaccine? No, it's not. Doctor, don't stop your statin. Keep taking your statin. God forbid if you get sick, your statin is going to help you survive. Okay, so not just preventing lowering cholesterol and helping, you're going to survive your like severe COVID infection, God forbid, if that happens. So it's an added more. And I have this conversation now quite often with my patients. Okay, ezetimibe. So ezetimibe, we know, it's kind of it's like a weak statin in terms of its ability to lower LDL. You get sort of a 20% LDL reduction. We have a couple of randomized trials, Improve It and the Sharp trial, and they both show. So the Improve It study showed an additional 6.6% reduction in cardiovascular events, with the reduction of LDL, say, down from 1.8 down to 1.4 when you add ezetimibe. And so then there's, then everybody talks about residual risk. So you get the LDL down to 1.4. Should we be getting the LDL down even lower, or should we be turning our attention to triglycerides, or what else should we be doing? Okay, let's come back to the patient, the farmer that I mentioned before. So these were then his, on the statin only. Remember, his LDL was 2.5. So the decision we made at the time, out of that multiple choice, we decided, just for expediency, the easiest thing was to add ezetimibe. So he would put on ezetimibe 10. So you can see his cholesterol came down from 5.4 to 3.6. His triglycerides came down. His triglycerides are still technically high, 2.5. HDL didn't change. His LDL is now 2.0. Non-HDL 2.4, ApoB 0.9. Okay, so these are all higher than threshold values. So for example, a threshold value that would make you think of that I still need to do more for the LDL is 1.8. A threshold value that I still need to do more for the non-HDL is 2.4. A threshold value for the ApoB is, say, 0.7. So he's still, there is room for improvement for his LDL, but then he's also got these high triglycerides. So this, case then raises, and then of course you can't do anything for, well, I shouldn't say you can't do anything for the LP little a. The LP little a is just telling us he's got risk, but we'll get to that in a little while. There is something you can do for LP little a, by the way. But the question here is, okay, at this point, the bifurcation, do you push harder on the LDL for this guy who's 40, MI at 41? Or do you turn your attention to triglycerides and then start, down the reduce it pathway? Okay, so what would you do next? Okay, at this point, okay, we'll just refer him to the lipid clinic. Or is this the point then where you would add, PCSK9 inhibitor, alirocumab or evolocumab? Or, oh yeah, his triglycerides are high. I remember from med school that fibrates are good for triglycerides, or niacin. Or does this patient fit the reduce it profile? Is this someone where you would add, 4 grams a day of icosapent ethyl? Okay, so let's just review some. So PCSK9 inhibitors, the great evidence that, for maximally treated statin patients with or without ezetimibe. So here we have like 2 outcomes trials, big, well conducted, internally consistent, showing almost exactly the same result, further 15% reduction in events. These trials were both actually relatively short-term trials. So the argument was, well, okay, if you'd continued them longer, you would have even had a greater, possibly absolute or relative risk reduction. But, it's 15%. And then in subgroups of patients, it's even higher. Relative risk and absolute risk, and numbers needed to treat are even better if you select your patient based on baseline risk. So we have, 2 trials that would suggest, okay, then maybe I should be looking at LDL. And then in evolocumab, the on-treatment LDL was 0.8, remember? And then for the Odyssey outcomes, it was a little higher. It was sort of around 1.2, 1.3. And then, of course, Odyssey showed the reduction in all-cause death. So you really can't go wrong. I mean, if you were thinking, okay, maybe this is the point where I would consider adding a PCSK9 inhibitor to this guy's treatment, you could not be faulted for that, right? It certainly, and now we have long-term data. So I have a patient actually that's been in clinical trials. So I was a an investigator starting in 2011 on the Rutherford studies for evolocumab. So that was for hereditary familial hypercholesterolemia. So I've had now my patients that have been on Repatha or evolocumab for 10 years. So I've got 10 years of experience now. So for me, these are now no longer new drugs or weird, like, these are like established long-term treatments. And the good news is that, they're still taking them. Nobody grew a horn, nobody, yeah, everybody's like, there's no side effects as far as we can tell. And the patients are still alive and they're doing well. And so this is a clinical trial. This is a 5-year follow-up, but we're now acquiring long-term experience. This is 5-year follow-up with evolocumab, and the results are very, very stable. I mean, the patients, there's 56% reduction in LDL. Then the question is, okay, well, these drugs, you're aware that they are, costly compared to other drugs. So if you are then, trying to think on a purely economic basis, or like you trying to maximize your numbers needed to treat or minimize your numbers needed to treat, yeah, then are there certain subgroups who might benefit more? So yes, there are. So then this is then showing various subgroups from that Fourier trial. And for instance, if you then look at the individuals who have multivessel disease on angiography, the numbers needed to treat are 29, say, compared to 50 in the overall study. So if you then limit it to those with multivessel disease, or you limit it to patients who had a recent MI, like within the last 2 years, or patients with multiple MIs, great more than 2 MIs, then the numbers to treat become more cost effective. Now, hopefully, as these drugs, eventually, who knows, maybe the cost will become more affordable, or there'll be like greater coverage, because in the grand scheme of things, it's not that expensive compared to what else we're spending money on in our society. Uh, but this is another cost consideration. Or here's another thing, diabetes. So I had, like debates with my McMaster friends, diabetes. Well, okay. Yeah, there's here a third of the patients in the Fourier trial had diabetes, and you can see their trajectory of events is higher. Um, and so the absolute risk reduction is more compared to patients without diabetes. So that's another subgroup. And in contradistinction to statins, there's no worsening of diabetes, or there's no new onset of diabetes. These drugs are quite clean with respect to that potential complication or profile. Here's another thing in peripheral arterial disease. So we really don't have a lot of great treatments for peripheral arterial disease. So on the y-axis here, so you've heard of MACE, right? Major adverse coronary events. This is male major adverse limb events, which is, basically talking about amputations. So patients who came into the study, then this is then the risk basically of amputation. So this is then treating the cholesterol with evolocumab and getting it down to below 1. You reduce by almost 50% amputation risk in patients who had pre-existing PAD. And then patients without pre-existing peripheral arterial disease, of course, the event rates are much lower, but the hazard ratio is even better. So there's multiple. This is a tertiary endpoint. So there's multiple benefits. It's like almost everything you look at with this class of drugs, and lowering the LDL further is a benefit. And now they're thinking, well, induction therapy. So when the patient comes into the unit with acute coronary syndrome, start it then, get them on, give them their first dose before they're discharged, so rather than waiting for, 6 months and then starting them later. And this is then just achievement of target levels, within the first month of when, starting evolocumab during the acute coronary syndrome. So this was mainly just an efficacy study done in Europe, EvoPax, but there is now an outcome study that is being done. And even with the strict European target of 1.4, remember I told you 1.4? So 90% of patients reach their target of 1.4 within 4 weeks. So this is the indication for these two drugs in Canada, alirocumab and evolocumab. So I didn't talk a lot about heterozygous familial hypercholesterolemia. There's a whole other lecture about that. But basically, these are the two indications. And then evolocumab has the extra indication that there's a severe condition called homozygous FH. And this is then for patients above the age of 12, although there are trials now using it even in lower age groups. So the Hauser study, where it is effective in certainly in children with heterozygous FH, and then in some children and some children and adults with homozygous FH. Okay, another COVID-19 question. So what about somebody who's like on Repatha or on an evolocumab or alirocumab and then becomes infected with COVID-19? So far there appears to be, first of all, no adverse, no worsening, no interactions. And in fact, if anything, because you're treating the risk factor, you're sort of maxing out the treatment of cardiovascular risk. So the same thing that you would see with statins is that we would predict that these patients would survive better if their risk factors are being adequately managed in terms of then the adverse cardiovascular outcomes from COVID-19. So there certainly, and then in terms of getting vaccinated. So I had an email with a patient this morning on Repatha who wanted to know, should he go for the vaccine? And I said, yes, absolutely, go get your vaccine. There is no contraindication. Definitely, please, if as soon as you get the notification, go get your vaccine. So okay, so that's enough about LDL. So now we have these new markers, ApoB, Lp(a), and triglycerides. So here, this is then your coronary plaque. So this is your, and then in the center of the slide. So, and this is then this concept of non-HDL cholesterol. So, and you'll see this in the new guidelines, and you've probably seen it in the old guidelines, but this is my way of looking at it. Okay, so here's your occluded coronary artery with all of this lipid, crystallized lipid, which is really cholesterol, and then, calcified as well. And the lipid that goes into the plaque is cholesterol that comes from ApoB containing lipoproteins. So ApoB, one molecule of ApoB. So the most famous ApoB containing lipoprotein is LDL, low density lipoprotein. And for somebody with normal triglyceride levels, this is 80% of ApoB containing lipoproteins are LDL. And then there's also these other ones, VLDL, which are then triglyceride, but these are mainly, then VLDL carries triglycerides, but it's got, for every 3 moles of triglycerides, it's got 1 mole of cholesterol. So it also carries cholesterol. So it's not the triglyceride itself, because the triglyceride actually does not get impacted in the plaque. The triglyceride melts away. It's kind of a very labile kind of fat. It doesn't actually stick pathologically in the plaque. It's the cholesterol. So, but these particles have cholesterol in them, even though they're mainly triglyceride rich. But like I said, they've got a 3-to-1 ratio of triglyceride to cholesterol. So it's the cholesterol in these particles that once these particles get into the wall, they become impacted. And this have terms like, remnant particles or triglyceride-rich lipoproteins and so on. So we know those are bad for you as well. And then there's also Lp(a). It's an ApoB containing lipoprotein. And we know, similar kind of thing. So really the only one good lipoprotein, so this is like, I think of, if you remember Harry Potter. So Harry Potter, and there's like this guy, Draco Malfoy, and he's always hanging around with these goons, and they're all so stupid, and they're all just like, and then there's like the one good little, hero, and that's HDL. And he's like the designated driver, so he's like, just just taking cholesterol out of the plaque, and there's no ApoB on HDL. It's only ApoA1. And so now, the one problem here is that if you pharmacologically try to raise HDL, that does not automatically reduce events. So we used to think that that would be good for you, but in fact, the clinical trials show that it's more complicated. But the clinical trials definitely show that if we lower these ApoB containing lipoproteins, which are summarized by non-HDL. So non-HDL is simply total cholesterol minus HDL, that all of this then, goons, the Philadelphia Flyers of the 1970s. So they're all contained within this non-HDL reading or non-HDL number. So it's mainly LDL, but then these other kind of sidekicks. And so, yeah, not to say that I told you so, but I mean, this was even back. So like there was a huge industry and a lot of drugs. I mean, a lot of drug trials and the CETP inhibitors and niacin and all of these trials. And anyway, so this was back in that 2008 where we were thinking that, well, maybe raising HDL might be, futile. So, turns out that maybe it was. But triglycerides, that is one that has turned out now in 2021 to be important in atherosclerosis risk for the reasons that I told you. And it's not really the triglycerides themselves. So these are like, hyperchylomicronemic blood, and then, lipemia retinalis, and then these triglyceride rich skin deposits. So it's really the fact that these triglyceride rich particles also carry cholesterol. So that's really the active moiety that contributes to atherogenesis. And so, triglycerides now, I mean, you get them, and, you have to think about them. And so we wrote this review a couple of years ago now. And so I see now that if you go on Up to Date and look for like the section on triglycerides on Up to Date, it looks like they've referenced this article quite a lot in that. So anyway, imitation is the sincerest form of flattery. So if any of you, want to get updated on what to do about triglycerides per se, then you could read this paper. And there's lots of, triglycerides are actually way more complicated than LDL. So all of these, secondary medical conditions that can raise your triglycerides. The big one being, alcohol, or, a high glycemic index diet, or being overweight. Diabetes, the main lipid disturbance in diabetes is actually hypertriglyceridemia. All these drugs raise triglycerides, so you have to, rule out the secondary causes. And then it turns out, so this point that I was making before about the cholesterol that's in those triglyceride-rich particles, it's actually then the cholesterol rather than the triglyceride that seems to be raising the risk. And so that this was then from the paper, and this shows then the whole universe of these here's Jupiter, and then here's Venus over here. And so anyway, the triglyceride-rich particles are chylomicron remnants, so the remnants of dietary, chylomicrons, so triglyceride-rich after you eat. VLDL comes directly out of the liver, and then the remnant of VLDL is called IDL. So it's really these particles which have then mainly triglyceride, but they also have cholesterol in them. And it's like I keep hammering, it's the cholesterol that's in these particles that also ends up in the plaque. So these, our friends from Copenhagen had this paper in JACC showing that it's the VLDL cholesterol that actually explains the risk, and not the triglycerides in the VLDL. Okay, so the triglycerides are a marker. They're telling you, and the triglycerides are doing other things. The triglycerides are jacking up inflammation, and they're telling you that the patient is obese, and they're telling you that there's insulin resistance also present. But really, the active moiety is the cholesterol in those particles, and even compares favorably to LDL cholesterol. So this is then their diagram of what they said was going on. It's the ApoB containing lipoproteins, the non-HDL. And the 50% of the risk is actually from the cholesterol in the VLDL particle in terms of then MI risk. So this is from the Copenhagen Heart Study. And this is then what is going on here. Okay, well, there's, modification, and, this is like, mechanistic hand waving. And not only that, but it looks like these particles are important in aortic stenosis, valvular aortic stenosis. So this was a genetic study where they looked at the gene loci that raise these remnant particles and raise VLDL and raise these remnants. And then they looked at development of aortic stenosis. So the big risk factor was, bicuspid valve. But then if you also had this genetic profile with high triglycerides, you were more likely to develop aortic stenosis in this Mendelian randomization study. So it's not only just bad for your atherosclerosis risk, but it's bad for aortic stenosis as well. Okay, so back to the patient. Okay, remember he's still on ezetimibe. Okay, so I'm now, so we're trying to think, okay, what are we going to do? Are we going to like pound down on the LDL, or are we going to think about the triglycerides, or what's the next step? What would you do next? And then the other thing is his LP little a is high. So here, okay, before we decide, there, that was the LDL side. That was the argument for the defense for LDL. Now I'll give you the argument for the defense of triglycerides, and that's this study, Reduce It. So Reduce It, they enrolled patients with statin. These were statin treated patients. In fact, the average LDL was about 1.8. These were fairly well treated on a statin. And then the triglycerides were between 1.5 and 5.6. And then half of them got placebo, and half of them got this purified form of omega-3 called icosapent ethyl, which is like pharmaceutical grade. And there was this amazing reduction in events. I mean, it was like miraculous. So, and so then the idea was, okay, well, it was through triglyceride reduction. So, and many of you maybe have been following this. So it didn't actually appear to be, so the triglycerides were telling you that the patients were at risk, but this drug really didn't do a whopping reduction on triglycerides, but it seemed to be having these pleiotropic effects like inflammation, anticoagulant effect, other metabolic benefits. And it was the blood levels of EPA, the actual fat that was, the EPA, eicosapentaenoic acid, that was the biggest correlate of the outcomes rather than the triglyceride level. And then, it's even more of, the time to stenting, time to grafting. I mean, these were like every endpoint that they looked at. And then even mortality was just missed statistical significance by, like a literally 1%. And then they looked at total events, so not just the first events, but there were like multiple, in these clinical trials, patients have multiple events. So 25% reduction in first events, and then 32% reduction in second events. So all in all, if you then look at, and there was like one person in this study who had 11 events. So if you look at the total events, it's 1,500 versus 1,000. So like a reduction by a third of total events. So it's really fairly amazing. And this is like not a statin drug or not an LDL drug. This is then, patients were enrolled based on triglycerides. And then the thought was you're actually treating that kind of triglyceride side of things. Now, what was the downside? So you're aware of this as well. There was like a 1% increase in adjudicated atrial fib or atrial flutter, but then even with that, the cardiovascular risk was reduced. And then in November, so that was with purified icosapent ethyl, or EPA, but then they then did a study with a mixture. So this is out of the Cleveland Clinic. This is the strength trial, where they used a mixture of the same total grams, 4 grams, but it was a mixture of DHA and EPA. So those are both omega-3 fatty acids, but the chemical structure was different. They used a different placebo, and there was no, like much different outcome. So of course, then the clinical trialists that did the Reduce It study were saying, well, it was because the agents are different. Whereas the investigators for this study, for the strength trial, saying, well, because the placebos were different. So like mineral oil versus corn oil. So you can't assume a class effect. So the Reduce It trial used EPA. So this is the chemical structure of EPA. The strength trial, that negative trial that I just showed you, used DHA mixed with EPA. So there was these extra two. So, it was not, like I said, you cannot assume a class effect. So if you're just going by what is evidence-based, if you use 4 grams of this versus 4 grams of a mixture of these two, the results seem to be different. Okay, so anticipate new treatment approaches. So you can think about what you would do for that patient. Would you then have gone for the PCSK9 inhibitor to get his LDL down further below 2, or triglycerides were 2.5? He was exactly the demographic for a Reduce It patient based on the triglyceride profile. Would you start him on icosapent ethyl? So here's what the Europeans say. The Europeans are now their target of LDL for everybody who's got any kind of high risk in Europe. European Society of Cardiology, European Atherosclerosis Society, the target LDL is 1.4. And if they're at really high risk, who've got like multiple events, maximally tolerated to like 1.0. So these are now guidelines in Europe. This is what they're using in Europe. So when you see the Canadian guidelines in a little while, you'll see that in fact our strategy is going to be a little bit different. It's going to be a little bit more like the American guidelines. So the American guidelines, and this was then following this innovation that was introduced when Todd Anderson. So I think those were like amazing guidelines from 2016, which Todd was still the chair of the committee. And that the concept there was the patient was a statin eligible patient or statin eligible conditions. So what are statin eligible conditions? Well, established cardiovascular disease or abdominal aortic aneurysm or chronic kidney disease or diabetes or familial hypercholesterolemia or somebody with a lot of risk factors. So the point is you choose your patient based on statin eligibility. So there's statin eligible patients, and then you use the statin to the highest intensity. And then here the US guidelines, I'm sort of paraphrasing here. If the LDL is still above 1.8, then the US guidelines would say adding ezetimibe is reasonable. They also say you could consider a PCSK9 inhibitor, but then add ezetimibe before doing that. So they still say ezetimibe is the first step. And then here they've got this kind of, small print. The dashed arrow indicates that PCSK9 inhibitors have randomized control trial supported efficacy, but they're not as cost effective because of the cost. So the Canadian guidelines, I think the cost is going to be less of a consideration. It's going to be more, I think what you will see is it's still this idea, because the LDL above 1.8, but how far above 1.8 is it? If it's like really far above 1.8, then, okay, you can still consider ezetimibe, and insurance companies still want you to use ezetimibe. But you are closer to the decision for PCSK9 inhibitor, basically. Anyway, Canadian guidelines are different. Oh, a sneak peek! Please don't tell anybody. Some of this is non-controversial. It's been reported. George Thanasoulis and Glenn Pearson actually showed these slides at the CCC. So, for example, something non-controversial: if there's a history of hypertensive disorders of pregnancy, that you should check lipids in those patients, in those women. So hypertensive, just like preeclampsia and so on. Some non-controversial recommendations. Okay, and these were in the 2016 guidelines as well. You can look at non-HDL or ApoB as alternate measurements. The triglycerides are high. The one innovation that was talked about was Lp(a). And so Lp(a) is something that you only would measure like just rationally, because it doesn't change. You could measure it once in the patient's lifetime. And if the Lp(a) is high currently, because we don't have treatments for Lp(a), you could intensify your LDL reduction. So some of us, so this is even, I think even before George, this is while George Thanasoulis might have been in primary school, 1997. So this was even something I wrote when I was at St. Mike's. Is it time to measure Lp(a) as part of coronary heart disease assessment? So that was like 24 years ago. So I think finally now, yes, probably the answer is yes. In 1997, the answer was no. So here's Lp(a). This is Lp(a). It looks like LDL, but it's way worse. It has this added moiety, apo(a), which then interferes with thrombolysis, and it's genetically determined, and your levels are constant throughout your life. But it turns out, so here's an added bonus. Maybe some of you already knew this, but the PCSK9 inhibitors, both of them, so this is just showing evolocumab, but it lowers Lp(a). So not only does it lower LDL, but as a bonus, and we still don't fully understand the mechanism of why this kind of drug lowers Lp(a), whereas a statin does not lower Lp(a). But we'll take it. It's a bonus. It's just So again, something to consider. So now at least somebody, where your patients have a high level of Lp(a), there is at the usual dose, 140 every 2 weeks. There is something we can do. And then coronary artery calcium, this was in the previous guidelines, but this is something also that you can consider. And then based on the REDUCE-IT trial, you can pretty much count on the fact that there probably will be some recommendation, a whole section on non-statins. And then this whole idea of this, if the LDL is managed, then the triglycerides are still between 1.5 and 5.6, then based on the results of the REDUCE-IT trial, you would consider icosapent ethyl. And then, what to do with your patients with genetic hypercholesterolemia, heterozygous FH. And then if you use supplements, there's no evidence for benefit. So again, I was hoping that these would be out by now and I could show you the algorithm. So I didn't, but I don't. So this is a made up algorithm. This is just a possible algorithm. Okay. This is again, everything that I'm talking about is like theoretical. Okay. It's not published yet, but it might be published soon. So here, this is also for sure not the algorithm that's in the guidelines, but it's an algorithm that I'm considering. So is the patient statin eligible? Yes. Then you do your weight, diet, physical activity. Then you start your high intensity statin. And then you look a stopping point. Is the LDL under 1.8? Oh, then these other tests, ApoB 0.7, non-HDL 2.4. If it is, then yes, start, then continue your treatment. Just keep them on the high intensity statin. No, then you've got options. Ezetimibe or PCSK9 inhibitor. And there, what probably would be the determining factor would be accessibility, cost, coverage, and how far the LDL is away from 1.8. And then once you've got the LDL under control, then you can turn your attention to triglycerides. And if you still want to help the patient out, then you can consider 4 grams of icosapent ethyl from the REDUCE-IT trial. Okay, so that's the end of my presentation. So hopefully I've convinced you, and certainly not this group, about the importance of early and aggressive LDL treatment. We have the unequivocal, independent trials showing that PCSK9 inhibitors reduce major cardiovascular events. Absolute reductions are highest if you want to then sort of select your patients. In the very high risk patients, the patients who have had multiple MIs or recent MIs or multivessel disease, or your patients with diabetes. And then we have this issue of residual risk. So residual risk then remains. You then have to look, am I doing as well as I can with LDL? Should I be then, treating it to an even lower level than I used to think was okay? What about the triglycerides? Are they between 1.5 and 5.6? And then, these remnants, ApoB, is that something that I should say, I personally think ApoB is a super useful test. And I've measured it like in thousands of patients. And so it helps me, like when we can't do the LDL, or then the patient has got high triglycerides, then the ApoB is something to hang your hat on. And there we're looking at a target of around 0.7, so certainly less than 0.8. And then Lp(a), we have no treatments for Lp(a) specifically, although the PCSK9 inhibitors lower Lp(a). And then coronary artery calcium, these other things that can help you determine the additional risk for your patients. And then just one last thing. So here's a slide showing evidence for our existing drugs with endpoint reduction, depending on whether you're on a background statin, no statin, or with statin. So bile acid resins on their own without background statin were shown to reduce events. The study with the background statin has not been done. Ezetimibe is the other way around. So with the background statin, you reduce it further. With ezetimibe, it is done. Fibrates in monotherapy, there are some results, but not with background statin use. Niacin, again, monotherapy, but not with background statin use. PCSK9 inhibitors never tested as monotherapy, but several. I didn't talk about Spire, but that's another consistent trial using bococizumab. And then with the high dose omega-3, it's the purified IPE that is a positive study on background statin. And then final thing, so this is part of another lecture. This was a research lecture that I gave, but it turns out there are all of these new drugs for lipids that are coming out. So right just at the top of the list here PCSK9 inhibitors. We have evolocumab and alirocumab, but there is also coming out inclisiran, which is a twice a year, a short interfering RNA. Then evinacumab was just, it's a monoclonal antibody by Regeneron that was just approved in the US about 3 weeks ago for severe hypercholesterolemia. Pfizer has vupanorsen. There's another RNA interference drug for this really amazing target. This is a great, I didn't talk at all about it, but this is sort of the future. So I think in the next 5 years, you will be seeing some of these drugs coming out. And then there are two drugs for LP little a that I mentioned before. There's pelacarsen and olpasiran. So olpasiran is actually by Amgen, and pelacarsen is Novartis. And then these other drugs for ApoC3 for really high triglyceride levels. So again, volanesorsen was approved in Europe, not approved in North America. Anyway, the lipid field is we're at an interesting time, especially now with biologic treatments and new targets. Anyway, I will end now. If any of you have trouble sleeping, I refer you to this article. It will put you to sleep within 5 minutes, and you don't need to take Zopiclone or anything. You can just start reading this. Okay, thanks very much for your attention. It's my honor to speak to you out there. Thanks.
Thanks, Rob. That was a fantastic overview, and we do have a number of questions. So there's a question from Dr. Raji in Edmonton. So if all that matters is the cholesterol in the no matter what particle, why not measure ApoB instead of LDL, TRGs, etc.?
Yeah, so I think that's so, Paolo. Nice to speak with you indirectly. So I think there's a good point. There's a good case that can be made for that. Absolutely. In Ontario, and so in Alberta, you're fortunate that you can actually measure ApoB, and it doesn't cost you anything. For me, I can't measure it. It's actually covered in the teaching hospital as part of the teaching hospital budget, but a community physician can't measure ApoB. So I think with ApoB, for sure it's a useful test. If you can measure only one thing, maybe ApoB is the best thing to measure, like the one ring to rule them all. But part of it is also education. So I think probably 5 years from now, maybe everybody will be measuring ApoB. So it's just, moving the field forward and educating the field.
Okay, there's another question. If there's a role for measuring oxidized LDL, and it's going to have a role in further risk stratification.
Yeah, so I think it's a good question. It's certainly something worth doing research on. The problem is those assays are super hard, like the assays from blood. To look at oxidized lipoprotein species, you have to be like OCD in terms of collecting them, and they are prone to artifacts. So I think if there was a reliable method, it's certainly something that could be checked. And certainly in the research area, we review research papers for journals that I'm involved with, and occasionally it comes up that the oxidized lipids are a marker that tells you more than just the plain LDL. So I agree with you. I think it's just not ready for prime time.
So Todd also agrees that this was a great talk, and wants to know if you have a lot of patients on both PCSK9s and IPE.
I wouldn't say a lot, Todd, but definitely I do have some. So there was one patient I saw even the last Thursday. Virtually. I'm doing them all virtually now. So he was on Repatha already. His LDL was 1.3, but he had quite bad family history, bad disease, and his triglycerides were still I think 5. So I started Vasipa with him. So I wouldn't say I have a lot, but I am starting to use that combination more often.
So Andrew Wong wants to know, where do the targets for ApoB less than 0.7 and non-HDL-C less than 2.4 come from? Because they used to be 0.8 and 2.6 respectively.
Right. So I think part of that is based on Canadian data. So that will be fully explained once the guidelines are published.
Okay. So Dr. Agarwal wants to know, what do you think is where does the difference lie between the recent omega-3 trials, strengthen and reduce it?
Yeah. So
what would be your opinion?
Yeah. So there was a lot of talk that it was really the difference in the placebo that was used, that mineral oil was actually a deleterious placebo, and it was kind of inflating the deleterious results, whereas corn oil was a neutral placebo. So I think, the regulators have really looked at that, and I don't think that's the major thing. So I believe, so first of all, the level of EPA that was achieved in the strength trial was only about 45% of the EPA level achieved in the Reduce It trial. So the EPA in the blood was much higher with Reduce It. And then the second thing is that there was the fact that there's a mixture of DHA, docosahexaenoic acid, and strength, which may be neutral, or possibly is having then like some neutral, maybe neutral or maybe deleterious effect. So again, I don't know, and I'm not sure if it's ever going to be sorted out. It's a mystery for Sherlock Holmes possibly to try to solve.
You think PCSK9 should be first-line therapy in diabetics?
See, I think it's I think it depends on the degree. So yeah, if you have somebody like, so again, it's the same principle. You max out with your statin, and then if the LDL is still high, so you're saying instead of statin, or you sort of go directly to PCSK9?
Go directly to PCSK9, yeah.
Yeah.
If there was no cost issue.
Yeah, I still think that's a really good question. PCSK9 inhibitors work better if there's a little bit of statin on board. So my experience is I have several patients on PCSK9 as monotherapy because they can't take a statin, and there you always get better efficacy from your PCSK9 if you at least have a little bit of statin around. So I still would be saying you should still try with the statin, although for some patients, I think I certainly have gone to PCSK9 as monotherapy, but not as the first choice. Always buy a statin first.
Okay, well, it's 9:01, so thanks very much. It was a great talk, and thank you for being with us. Hopefully next time you can be with us in Calgary.
I look forward to it, and take care, everybody. Have a good spring.
Okay, bye now.